Hey everybody, I'm super excited to introduce you to Andrew Sun. He is our advisor for men's sexual and hormonal health. He's a urologist in Texas, trained at Harvard, UCLA, has a fellowship training in men's sexual health and andrology. I think you're really going to enjoy this. If you're a man, or if you know a man or love a man and you want to know how they can better take care of their testosterone and their health. So sit back, enjoy. Hey, Andrew, thanks for joining me today. So to start out, would you mind just giving the audience a little bit of your background?
Sure. Yeah. Thanks for having me, Jared. My name's Andrew Sun. I'm a board certified urologist with fellowship training in male sexual medicine and male infertility. From Maryland originally, grew up there, went to college at University of Maryland, did my medical school at Harvard, and then residency in urology at Cleveland Clinic. After that, we do what's called a fellowship, which is dedicated extra training, and I did mine at UCLA, specifically in andrology, which essentially means the study of man and male-related issues. So male sexual dysfunction, male hormones, male infertility, that kind of stuff. Currently, I'm in DFW, Dallas, Texas area in a large private practice group where I direct a men's health center and focus exclusively on these kinds of men's health issues.
Very cool. Now, with many of my guests who are physicians, I've kind of picked their brain, like, how did you end up getting into this field? So I'm curious for you, like, how did you end up kind of moving into this field and what interests you about it?
Yeah, it's a good question. When I went into med school, I thought I was going to do neurosurgery. I think just because I thought it was cool to say that I was a neurosurgeon. And then when I got there, I kind of met a urologist, and I didn't know what a urologist was, but I thought what they did was really interesting. Some medical stuff, some surgical stuff. But at that time, I wanted to be a urologic oncologist focusing on cancer because the surgeries are big and they're cool. And then about third or fourth year during residency, I did a rotation at the VA, and everybody does the rotation at the VA, and it's something of like you love it or you hate it, and I loved it, and I really enjoyed talking with these guys about their like male sexual issues. I found it to be fun. I found it to be a little bit more casual. I found myself enjoying the work environment a lot more, and I realized just how poorly a lot of times men take care of themselves and how much worse their health is, a lot of which is our own kind of doing. And so I decided to focus on this like quality of life, male sexual medicine stuff, went out to UCLA, and there it is.
Very cool. I find it such interesting, like male sexual health, like I feel like women's sexual health is having this big moment. Like there's a lot of talk about menopause, there's talk about testosterone for women, and there's new drugs for women, and 100% they deserve it. They need medications. Like I think they've been ignored for years. But I feel like men's sexual health has been like so simplified into like either you're having trouble with an erection or you're not, or like it's very simplified. And what I think I like that you called out is kind of quality of life. And it's not about just can you get an erection or not. It's actually about like how do you enjoy life, connect with your loved ones, things like that. So I'm curious, and it's interesting that you found that in the VA, because usually the VA is for those not in medicine and who have not practiced in the VA. The VA is just a very interesting kind of place.
Yeah.
What was it that, like, just take me a step deeper, like what was it there that kind of caught your interest and thought, I really like the good that I can do in these people's life?
Yeah. The VA is a very interesting place. And I think there's in my experience, there's two patient populations in the VA. There's like the Vietnam guys, and then there's like the younger sort of Middle East Iraqi war type kind of generation, I guess. And the Vietnam guys are definitely a colorful bunch. And I don't know, I think I just really enjoyed interacting with them. But unfortunately, a lot of them have a lot of significant medical problems, right? Diabetes, high blood pressure, just like terrible kind of general care. And they have all these downstream ramifications of it. And I realized that even with all of that, what they mostly wanted to talk about was their sexual health, was their like testosterone, was like a lot of these things. Like if I could harp on them about their high blood pressure all day, and ultimately and like most men, they just like in one ear out the other. But once I start talking about their erections or their sex life, then they kind of perk up, like no pun intended.
Yeah.
But what you really realize is that like all of the reasons that you get erectile dysfunction and sexual dysfunction and all that stuff, they're still the same fundamental metabolic syndrome type things, right? High blood pressure, high cholesterol, diabetes. And so if the ultimate goal is still to treat those those like disease processes, then wouldn't a creative way of actually activating men to invest in their own health be to target those symptoms that they tend to care more about, which, let's face it, is testosterone, sexual health, fertility for younger men. And so that was the other side of it. I saw this younger generation of guys, right? They've been abroad, deployed, and they come back, they're starting families, they're tired, they may have gone from like a very, very active, high environment to like civilian life, and like kind of there's a big psychological change there, but there's also like now they're starting their families and they have fertility issues and that's the age at which, if you don't get them into the medical system and take care of those issues, then they eventually become that Vietnam era guy, in a wheelchair with like one leg because it's been amputated, with all of these accumulated medical comorbidities. So it's the identification that the fundamental disease processes of metabolic syndrome that we want to treat, you can get men to treat them better by targeting those symptoms that they care about, and B, do it at an earlier age so that you can prevent those downstream consequences. Historically, urology, our general patient, when people think of it, is like a Medicare-aged 68-year-old guy with enlarged prostate or something. But I wanted to kind of shift that and say we should be targeting this younger generation and getting them engaged in their healthcare so that we can prevent those issues as they get older. And that was kind of my revelation, I guess.
Yeah, I love that. That's super cool that you kind of saw it as this gateway to better health all over, like global health.
Yeah.
And it's so true. Like it's all tied together. Metabolic health leads to worse health for everything downstream. So I'd love to dig in a little bit more and just have you educate kind of when you think about the male master hormone, testosterone, like how do you think about its function, what it does for men, what a lack of it does, and how do you talk about that with your patients?
Right. So fortunately, most patients come in armed with some understanding of what testosterone is. Now, it's an incomplete understanding because most people think, based on popular media and stuff, it's just muscles and sex and like that kind of stuff. And it is those things. And it's also a lot more than that, right? It controls male sexual development, of course. It controls sperm and fertility production, muscle mass, but also just like energy, the ability to literally like think clearly, such that if you lack testosterone, you get this very pronounced brain fog and you can't think clearly. Energy, metabolism. I try to almost tell patients that testosterone is just another arm of metabolic like health, and metabolic syndrome, as we'll get into later, is the number one cause of low testosterone. It's not actually aging. Yes, there is a decline in testosterone as you get older, but really the cause of low T is the accumulation of comorbid health factors, essentially metabolic syndrome, right? The same diabetes, high blood pressure, high cholesterol stuff. And so it does all of these things. And therefore, when it's low, you can have deficits in all of these things. Now, it is difficult to be a testosterone doctor in the sense that most of those symptoms are rather nebulous and they can have lots of other explanations for them besides testosterone. And so not necessarily is testosterone like the one trick pony kind of cure all for everything, but it definitely can be a significant piece of it, especially if they actually have low testosterone. And you can have it at any age. It's not just something that happens when you're 60 or 70. I have 70-year-olds who have testosterones that are fantastic, 700, 800, and I have 25-year-olds with testosterones that are in the 150s. Usually they're morbidly obese. They have a lot of other issues. And in the same way that I use testosterone, I also use sperm. The fertility, the sperm, just trying to tell people, like, if you have a healthy body, you probably make healthy sperm. And if you don't have a healthy body, you don't make healthy sperm. And with the exception of a few kind of genetic, rare things. So if you gave me a guy's testosterone level and his semen analysis, I could probably give you an overall picture of like on the spectrum how healthy this guy is or isn't. Super critical. We jokingly call it like we call the penis or the testosterone levels like the sort of check engine light for the body. If you look at our clinic, there's a lot of cars on posters, and we use a car analogy a lot because it kind of appeals. And it's just that's the check engine light, and when that comes on, that's when you know that something under the hood requires fixing.
Interesting. And so one question I have is, so a man comes in, he's got a testosterone of 150, and it's appears to be somewhat metabolic. And so what's your discussion with that person at that point? How much is it the lack of testosterone giving them extra drive and the ability to think and all those things and needing replacement versus, hey, you really just need to buckle down, eat healthier, exercise, those kinds of things? What's your discussion with your patients around that?
Yeah. So when we screen the low Ts, or oftentimes they'll come in and their primary care doctor has checked their testosterone. Then I take the next step and start to check some other hormones. I want to know if the patient has low T. You basically only have two potential sources of low T. Either your brain is not working well or your testicles are not working well. If you have low T and you have low brain hormones, FSH and LH, the stimulatory hormones for testosterone, that implies that you have stress, lack of sleep, lack of exercise, a variety of things, that you have hypogonadotrophic hypogonadism, which just means your brain's not telling your testicles to make enough testosterone. Your testicles could do it, they're just not getting a signal. It's different than a guy who comes in with high FSH and LH and low testosterone. In that situation, the brain is basically like screaming at the testicles, hey guys, make some more testosterone, but the testicles can't do it. And that's usually either if they have genetic issues. As you get older, we tend to see that phenotype more because the testicles they're older, so they require more stimulation. And more likely that guy just needs testosterone replacement, whereas the guy whose testicles could still do some more, he might benefit from some things that could boost his testosterone. And it is a chicken or the egg thing. They usually come in. The number one, people think that I'm mostly treating sexual dysfunction, but by far the number one symptom that I treat is being tired. They just come in and they're just tired. And you check their testosterone and it's low, and they're like, oh, that's why I'm tired. And it's a cyclical downhill thing where you get more tired, you work out less, you eat more, your T goes down, your T's down now, so you get more tired, and just keeps kind of cycling on itself. And to break that cycle, yes, we always counsel our patients to sleep better, to eat better, to move more. These are all critical things. But as you sort of find in reality, most people need a little bit more than just that sort of thing to be harped on. And so I tend to think of testosterone therapies as like a pharmacological sort of shot in the butt, while I'm sometimes literally, sometimes figuratively, to get them started on this journey, such that I know that the fundamental causes of their low T are all of these lifestyle things. And we both know, me and the patient, that those are the things that we need to fix. But in order to get him to do it, I'm going to put him on testosterone maybe for a year, maybe for 2, maybe for 3, maybe forever. It depends. But the goal is to put him on it for a certain amount of time to give him that bolt of energy and drive and motivation so that he can make those positive lifestyle changes, so that eventually he doesn't need the testosterone anymore. Then we've really achieved the goal.
Yeah. And so you kind of talked about kind of low testosterone from central messaging, and then low testosterone from testicular failure or atrophy. And it sounds like sometimes you'll see reversal of kind of central. Will you ever see reversal from peripheral, like testicular failure?
Yeah, you can, and it depends mostly on the guy's age. I mean, if the guy comes in and he's like 80 and he's got like high FSH and LH and low testosterone, you're probably not going to change that. But sometimes we do see that phenotype mostly in the morbidly obese guys. And so we remember that the whole reason that men have scrotums is because the testicles want to be a little bit colder than the rest of the body, right? That's why when it's hot, they get loose. When you jump in a cold pool, they suck up. They're trying to regulate their temperature. So when you get really obese, ultimately, because of the fat on your thighs and your belly, and like the stereotypical patient here is an obese truck driver, right? And unfortunately, the average truck driver tends to be more overweight, and they're sitting for many, many hours a day, and the testicles are essentially baking between their large thighs, which means the testicular environment is just extra hot all the time, and they don't like that. And so they don't function nearly as well. We will often see in those guys, if you lose 10, 15, 20% of your body weight, massive, many, many hundred level increases of testosterone, from 250 to 800, just from a huge amount of weight loss. So it is reversible if it is caused by lifestyle, and if the guy is young enough that he still has more potential. But of course, sometimes in like the case of Klinefelter syndrome, which is when you have an extra X chromosome, 47XXY, they usually have low testosterone, high FSH and LH. You can't fix that, right? That's a genetic thing. But ultimately, there is almost no patient for which or for whom the lifestyle management will not be at least somewhat helpful. For some, it's all they need, and for some, it's just a piece of the puzzle.
Yeah.
So.
Now, is there any danger, say somebody gets screened by their doctor, their primary care doctor is working them up, and let's say they're a little bit older, they're like 60, 65 years old, something like that.
Yeah.
And they end up having a T of like 150, but they say, hey, doc, I feel fine.
Yeah.
The doctor does another check, comes back 150 again. They send them to you for like third check. They've done kind of other workup, checked like prolactin to make sure there's not a tumor or anything like that. What's the risk of them staying with low testosterone? Why not just live like that?
So we used to just kind of hand wave about this. Now we actually have data. Literally about a month ago, maybe two, big meta-analysis was published in the Annals of Internal Medicine, basically trying to answer this exact question. Is there such a thing as dangerously low T? We've learned over time that having normal testosterone is good. Having high normal is fine. There are extremes above which you shouldn't have, like too much, testosterone causes acne, baldness, high blood pressure, polycythemia, which is your red blood cell count kind of getting thicker, a lot of things. But where is the floor, and at below what level does it become dangerous? There was some long-term data, again, from the VA, Molly Shores, who published basically a bunch of patients, normal T and low T, and just tracking nothing but overall survival over time, and seeing that essentially the patients who had low T, they died earlier, and they died, of like more heart disease. There's been a thought for a while now that testosterone, when it's really low, can be a risk factor for cardiac disease. Now, there was this very controversial paper in 2014, which got everybody scared, that said that testosterone replacement therapy caused cardiovascular disease, which has basically been conclusively proven to be untrue. That paper had a lot of methodological problems. 10 or 13% of the patient population was actually women. When you scrubbed out the data, like all the conclusions kind of went away. But it scared a lot of people, and it's been kind of the prevailing ethos for a while. The best paper on this was last year in the New England Journal of Medicine, 5,200 patients randomized to testosterone gel or nothing. And basically those patients on testosterone had no more increased risk of cardiac events than those patients who weren't. But again, to answer your question, on the other side, this Annals of Internal Medicine paper basically showed that if you have a testosterone level below about 210, then your all-cause mortality actually increases by a relative risk ratio of like 1.3. Not a huge thing, but like definitely there. And then if it's below like 150, you have about that much 1.3, 1.4 risk of elevated of major adverse cardiac events, right? Heart attack, this or that kind of thing. And that jives with a lot of our general overall survival data. So to sum it up, basically, happy middle, great. If we treat people, sometimes we like to treat them to the upper third of middle because you get better performance and athletic activity and that kind of thing. But I usually tell patients, if they're like 275, I'm like, look, you can treat it. You don't have to. It's up to you. But anybody who's below 200, they're more likely to get a benefit from therapy. The lower you start off with, the better you're going to feel when you actually get on therapy. And B, there is actually probably some medical risk to being too low, probably like below 200 or so. And it's not just the cardiac thing. It also, testosterone is important for bone health. And so being below, 200 will actually affect that. And who knows what else. We have some data showing that if you normalize those guys, their metabolic syndrome pieces get better, right? Their insulin sensitivity improves, their triglycerides go down, a lot of sort of beneficial things. So again, I treat it as like a portion of metabolic syndrome.
Yeah, that's really interesting. I'll have to look at that most recent paper. I hadn't heard about that. So that's cool.
Yeah, pretty cool. It's an Australian group. I'll send you the paper.
Yeah, that would be great. The other trial that you talked about, the Travers trial, was what was so interesting to me about that paper, of course, was they used high-risk individuals. These were people with heart disease,
right,
with metabolic disease, and no increased risk of major cardiac events, which was great to see. I think many of us who have treated men kind of thought that's what we would find, what they would find. So it was great to have the evidence.
Yes, it was a very, very pivotal study. Now, the one criticism, which I think is a reasonable criticism, is that that study compared gel versus placebo.
Yep.
Does that translate into the guys taking like high dose injections? I would say partially, but incompletely, right? And so I think what it does show you is that normalization of testosterone from objectively low to normal is safe. But what we don't yet know is that high range, like we can't say conclusively that that is also purely safe, right?
Yeah.
Yeah.
Well, and the other interesting thing about different forms of testosterone is how the peaks of those go.
Right.
Where gel versus oral versus shots versus pellets, whatever man might be receiving. So I'd
Yeah.
love to hear like how you talk to your patient about, hey, okay, so you have low T, you want to do something about it, I want to do something about it. Let's talk through your options of how we take care of this. How do you kind of talk about that?
Yeah, for sure. So kind of going back to, I think from a while ago, there's two types of patients. Patients who can increase their own testosterone or patients who just need to rely on external testosterone. So the first bucket, the patients who can benefit from increasing their own testosterone, they tend to be a little younger, and they're definitely the guys that have primarily sort of metabolic reasons for them to have low T. In those guys, if you can tell the brain to tell the testicle to make more endogenous internal testosterone, in a way, that's actually the healthiest situation because you've built up the own system. When you do that, you simultaneously improve or at least maintain spermatogenesis, sperm production. And, it's a very sort of holistically beneficial way to do it. So there is no FDA approved medication that does that. What there is a medication called clomiphene, which is mostly made for women, but we use it in men. And we basically take that as a pill and it increases the brain hormones and tells your testicles to make more testosterone. Sadly, it only works about half the time. And a lot of guys who take Clomid, even though their numbers increase, their symptoms don't get that much better. There's a lot of nuance about estrogen blockade and different things that I don't need to get into. But suffice it to say, that's the primary medication that we use for that boosting version. There's a second thing that we use pretty commonly called anastrozole. Men only make estrogen from testosterone. So estrogen gets made by testosterone through an enzyme called aromatase. If you block that enzyme, then you produce less estrogen and you save more testosterone. So that's what this medication does. This enzyme, aromatase, is present in fat. So the more fat you have, the more you convert the testosterone to estrogen. That creates estrogenic effects like having man boobs and that kind of stuff. And so that's a benefit. So sometimes, very often, we'll combine clomiphene and anastrozole as a sort of boosting regimen. For some patients that works, for a lot of patients that doesn't. And so if it doesn't, then we get into testosterone replacement, right? And the key word is replacement because you are just giving them testosterone. Anytime you give somebody testosterone, their body will sense this external testosterone and say, hey, we got a lot of testosterone. We don't need to make as much anymore. And so no matter what kind of testosterone you take, your brain is going to produce less of your own. That means inherently testosterone is a permanent therapy, although there are, as we'll get into, there's a lot of different variations in the types of testosterone with respect to how much they shut down your internal system. So I'm talking to the guy, I'm like, all right, you got low T, you want to do something about it. Do you want to do a boosting thing or do you want to do a replacing thing? And again, the younger they are, if they're actively trying to have children, that kind of stuff, then I recommend the boosting stuff. But if they want to do replacement, I tell them the spectrum of replacement options is essentially a trade-off between how often you want to take it and how invasive it is to take. So pills, least invasive, easiest to take, twice a day. Gels, kind of pretty minimally invasive. You just rub it on, although it can spread to other people, so that can be an issue, once a day. Injection, fairly big needle. You got to stab yourself with it once a week, could be twice a week, sometimes once every 2 weeks. A lot of variation there, but usually that's that. And then something like a pellet, well, we put those in the butt. It lasts for 3, 4, 5 months, and so that's one piece of it. Is the convenience and the trade-off. The other piece of it is the way, as you said earlier, the way the peaks work, right? So the way I like to think about this, natural testosterone is not always high. It's a cycle up and down, like it follows your circadian rhythm. This is why a lot of doctors will tell you have to test your testosterone in the morning because morning testosterone levels are always at their highest. Now, as you get older, that morning to evening variation actually blunts. And so, in the older the guy is, there's not as much variation. But the younger he is, there can be a huge variation in the morning and the evening. So, you have high T in the morning, it slowly drifts off throughout the day. It's low at night, and then you sleep, and then you regenerate testosterone during sleep. That's why the number one cause of low T is poor sleep. So, if that's the case, then theoretically, the best way of following that circadian rhythm would be to do a daily testosterone that you take in the morning, which is usually a gel. The issue with the gel is that they just don't work very well. The absorption is super variable. People don't get very good levels, and there's this risk of accidentally transmitting it. There was an episode on House about this. Like, dad was taking testosterone, and the kids were going through like precocious puberty, and it was because they were like hugging, right? So we don't love the gels. The thing that I mostly use as my first line therapy is the pills. They're relatively new. They came out in 2019. They're more widely available now as of 2022 because it was hard to get a version of the pill before. And it's twice a day, but you can take them in such a way that you recreate that circadian rhythm. So I tell my patients to take one dose in the morning and then one dose around lunchtime. And that way they have testosterone during the day, but that lunch dose has mostly faded off by the evening. And then overnight, they don't have testosterone exposure. When you have a period of time where you don't have external testosterone exposure, your brain is then going to sense a low T environment, which means it's going to have an opportunity to say, hey, we still need to make some testosterone. And so in those patients, I find that they still produce some degree of internal testosterone. They don't, quote unquote, shut down their factory completely. And therefore, they don't get one of the symptoms of shutting down your system completely, which is your balls shrink, right? Your testicular atrophy. So injections, when you take it, you basically have to take an injection that will last for a while, which means it can't do this like daily cycle. It will have to get this high peak, and then it will kind of like go down over time. When you do that, you're going to get like a supraphysiologic level of testosterone that's going to be like kind of high for a while. And unfortunately, that's where you can get some of the side effects. And so injection patients have a higher rate of things like polycythemia, your red blood cell count increasing, of acne, of losing your hair, and like that kind of stuff. And then finally, there's pellets. Pellets are essentially like a super long-acting version of an injection where you put them in the butt, and they very, very, very slowly elute over about a 3 to 4 month period. From a day-to-day basis, you'll have very little change in how you feel. But from like week 2 versus like month 3.5, you can definitely have a significant difference. So you don't feel quite as even as if you did it on a more like kind of cyclical basis. So nowadays, I would say, the bulk of my patients by sheer number are still on injections because that's the most common. But most of my new patients now are taking the pills. I don't do very much in the way of gels. And then some of the guys that just want like an easy kind of set it and forget it way of doing testosterone, they'll take the pellets.
Yeah. The one thing I've been curious about with the pills, since they're a little bit newer, like a lot of men, what they're kind of looking for with testosterone is increased muscle mass, increased ability to work out, get stronger. Yeah. And with injections, you kind of have, like you said, this higher peak and then this slow decline. So it seemed like kind of area under the curve would be larger as far as how long your testosterone is high compared to kind of like the peaks with the pills. Do you actually see that in practice? Do you see that some men, they're like, I really want the injections because I feel like I have better kind of physical performance, and other men are like, oh, I'm okay with the pills just because it's easy. I don't have to give myself a shot.
Yes. I think that if you really want to achieve huge gains, bodybuilder level stuff, probably the injections are the best way to go. I agree. I think there is an area under the curve effect. I have a lot of patients that take the pills and they feel amazing when they're working out because the pills peak at like 3 to 4 hours. So they just learn to time the pills before, and they feel amazing while working out. But an unanswered question, which I think is scientifically interesting, is when you're working out is not actually when like muscle creation is happening, right? That's happening many hours later. And so if your T falls back down low at that point, like maybe that's not the right time. So then the sustained area under the curve, I think for a guy that's purely into like getting huge, probably the injections, and they'll just have to be willing to tolerate the side effects more. That's not my average guy. My average guy is looking for increased energy, mental clarity and just like feeling more like peppy and energetic and whatnot. And it wants to do so in a way that limits side effects and kind of restores their standard metabolic or like circadian rhythm. And so then I use the pills. But I agree with you that like some guys, they'll just feel better on the injections at a high dose. Fine. Some guys feel better on the pills because they're more even. Fine. Some guys have side effects on the injections. I switch them over to pills. Some guys take the pills, but they don't get quite as much gains as they did on the injections. We'll switch them to injections. Ultimately, it's very, patient dependent, depending on how each type works with their body and what their goals are.
Yeah. Yeah. I personally, I really love prescribing the pills when it's so much. I feel like it's lower risk. I don't see the polycythemia, the high red blood cells. You just don't see it. I don't see hypertension as much. Like the side effects that I worry about when I put somebody on testosterone, I just don't see it with the pills. And I actually was meeting with a patient today who had super low T, 200s, for like fairly younger gentleman, like 40, 41. And he's been on the pills for like, I guess, 6 months. And he just put on 17 pounds of muscle. And like, obviously he was not pushing weightlifting or protein before he started, but you can get great performance, especially when you're hypogonadal, when you're low testosterone and you switch to testosterone, you start working out, you start eating right. Even with the pills, you can have really good outcomes.
Absolutely. I think it's whatever version of tea you're getting, it's definitely better than nothing. And it doesn't require injections. I fully agree with you. Certainly from a physician's perspective, managing the pills is 1,000 times easier because, like you said, all those things that we worry about, they don't happen, or they happen very, very infrequently. And I think it's definitely a significant thing. And just as an aside, like, we have all these patients now on GLP-1s, right? Like Ozempic, Wegovy, whatever. And because they go into this like severe calorie deficit, because they're just not hungry and they're not eating, they lose weight. But I'm sure if you've seen the studies as well, they become sarcopenic, right? They lose a lot of muscle. Yeah. But then you tell them, okay, you got to maintain protein intake, yes. Then you have to like tell them to maintain some degree of and weight resistance exercise to kind of keep some activation energy to those muscles. But then you also need the, let's face it, anabolic steroid, which is what testosterone is, to drive muscle protein synthesis. And so I think the true like master combination of weight loss is like diet modification, lifestyle change, GLP-1 agonist, Ozempic, right? Adequate protein intake, weightlifting, and testosterone. And then you lose fat, but not all your muscle. And it's great.
Right. Yeah. No, I think you're right. Andrew, I promised I wouldn't take your whole evening. You worked a long clinic day. Thank you so much for your time. Before we finish up, anywhere you want to point people that they can come learn more about what you do, about your practice, anything like that?
Yeah, sure. So our practice is called Urology Partners of North Texas, or our website is www.upnt.com. Certainly anybody who's in the greater DFW Metroplex or North Texas area, or Texas as a whole, because we also do telemedicine, welcome to come see us. But obviously, if you're not in Texas, or if you are, or if you're anywhere in the country, I'm a big supporter of Bionic Health and what you guys are doing, Jared. I think it's an amazing kind of program. I'm an advisor for your platform, and so I help out with some of the male hormone stuff, and it's definitely another way to access this vital kind of healthcare, but hopefully with a more, I don't know, from the ease of the comfort of your home, or however you want to say it, right? Like, as long as patients are getting the care, because I think truly, on healthcare, men are the underserved population. And again, a lot of that is because it's our own dang fault, because we don't go into doctor, and we don't have what women have, which is an OBGYN, right? Everybody has a pediatrician. And then when you become 18, 19, women have an OBGYN. You go for a yearly pap smear. That's basically your primary care doctor. Men don't have that, and they're just not likely to go seek that care. And if something happens, they're like, I'll have a beer, it'll be fine, until something really catastrophic happens. But the problem is that from that 18 to like 35, 40 time period is when you start accumulating all of the lifestyle factors that will end up causing heart attacks at age 50 and like obesity and all this stuff. And so, you know, get the health taken care of, and it'll be, you know, it'll pay dividends for the rest of your life.
100%. And I love kind of you bringing home the whole sexual health, male health. It is just health.
Yeah.
In the end, it just comes down to like, how do you help men be healthy? So
Right.
I love your work. Thank you so much for all your support and for your help. This has been really great. Thank
For
you.
sure. Thank you. Yeah, no, my pleasure. It's great.